It's a pleasure to be with you. The title of this session is Organization and Financing of Public Health, Part 6, CDC, Environmental Health, Injury Prevention, and Occupational Safety. There are no disclosures for this presentation. Objectives include review the major goals of the National Center for Environmental Health, discuss the health threats of climate change, review the major goals of the Agency for Toxic Substances and Disease Registry, ATSDR, discuss the 3 top toxic substances on the ATSDR Toxic Priorities List, review the major goals of the National Center for Injury Prevention and Control, review the leading causes of unintentional injury deaths in the United States, review the major goals of the National Institute for Occupational Safety and Health, NIOSH, discuss the difference between NIOSH and the Department of Labor's Occupational Safety and Health Administration, OSHA. The last 2 sessions focused on the CDC's National Center on Birth Defects and Developmental Disabilities and the National Center for Chronic Disease Prevention and Health Promotion. We'll now discuss the CDC's National Center for Environmental Health and the Department of Health and Human Services, DHHS, Agency for Toxic Substances and Disease Registry for Environmental Issues. We will also discuss the National Center for Injury Prevention and Control and the National Institute for Occupational Safety and Health, NIOSH. The National Center for Environmental Health, NCEH, works to prevent illness, disability, and death resulting from human interaction with environmental toxins. The center conducts surveillance and applied research, supports educational campaigns, develops standards and guidelines, and offers training to state and local health agencies in environmental health prevention and response. The center promotes a healthy environment to prevent premature death, avoidable illness and disability caused by non-infectious, non-occupational, environmental, and related factors. The center is especially committed to safeguarding the health of people who are at increased higher risk, such as people from racial and ethnic minority groups, people with lower socioeconomic status, children, the elderly, and people with disabilities from environmental hazards. This is a partial list of environmental health issues addressed by the center: air quality, carbon monoxide poisoning, chemical exposures, lead intoxication, climate change, food safety, mold, natural disasters, noise pollution, nutrition, radiation, safe water, vessel sanitation. Many of these issues are interrelated. For example, climate change impacts several other environmental concerns. Human-induced climate change is a significant threat to health globally. Rising greenhouse gas concentrations result in extreme temperatures, changes in precipitation, increases in the frequency and intensity of extreme weather events, and rising sea levels. These climate-associated changes impact food and water sources, air quality, weather threats to populations, disease transmission through food, water, and vectors, such as ticks and mosquitoes, and human stress impacting mental health and well-being. Climate change affects human health in 2 major ways: changing the severity or frequency of health problems already affected by the climate or weather factors, and by creating health problems or health threats in places where they have not previously occurred. These climate threats are expected to worsen as the climate continues to change. Increases of greenhouse gases lead to extreme temperatures, expected to cause increased deaths and illness from heat and decreases in deaths from cold. Extreme temperatures compromise the body's ability to appropriately regulate its temperature, resulting in heat cramps, heat exhaustion, heat stroke, and hyperthermia during times of extreme heat, and hypothermia and frostbite during times of extreme cold. Extreme temperature can worsen chronic conditions, including cardiovascular, respiratory, and cerebrovascular diseases, and diabetes-related complications. Prolonged exposure to high temperatures is associated with increased hospital admissions for cardiovascular, kidney, and respiratory disorders. Climate change affects the air we breathe, including ground level ozone, O3, fine particulate matter, and airborne allergens due to increased plant growth due to increased carbon dioxide, CO2 levels. Poor air quality negatively impacts the cardiovascular and respiratory systems, particularly for those with underlying cardiorespiratory diseases. The maps on this slide show two different models for the 2030 projected change in average daily maximum temperatures, change in daily 8-hour maximum ozone levels, and excess ozone-related deaths by county. Areas with increased ozone levels have increased projected ozone-related deaths. The largest increases in ozone deaths are projected for the southwestern U.S. Extreme weather-related events associated with climate change will continue to increase in severity. The graph on this slide demonstrated lives lost and economic impacts of extreme weather events from 2004 to 2013. Hurricanes caused $392 billion in loss and approximately 1,050 deaths. Heat waves, drought, $78 billion and 1,200 deaths. Tornadoes, $48 billion and 1,300 deaths. And flooding, $30 billion and 750 deaths. Deaths and injuries not only occur during extreme weather events, but also during activities associated with disaster preparation and post-event cleanup. Health risks may also occur long after the event because of damage to property, destruction of assets, loss of infrastructure and public services, social and economic impacts, environmental degradation, and other factors. The severity and extent of health effects associated with extreme events depend on not only the physical impacts of the event, but also the existing human, societal, and environmental circumstances of the area impacted. Vector-borne diseases are illnesses transmitted by other organisms, vectors, like mosquitoes, ticks, and fleas, transferring infections from a carrier host to another susceptible creature like humans. The seasonality, distribution, and prevalence of vector-borne diseases are influenced by climate factors, primarily temperature extremes and precipitation patterns. Other factors impacting vector-borne diseases include how pathogens adapt and change, the availability of hosts, changing ecosystems and land use, demographics, and human behaviors. These complex interactions make it difficult to predict the effects of climate change alone on vector-borne diseases. For example, the increased distribution of Lyme disease in the United States from 2001 to 2014 as demonstrated on this map, was likely influenced by climate change impacts on the tick vector that transmits Lyme disease. Lyme disease is a bacterial infection caused by the organism Borrelia burgdorferi and is transmitted between susceptible hosts by Ixodes ticks, also called black-legged ticks, while feeding on mammals including humans, birds, reptiles, and amphibians. Adult ticks are about the size of a sesame seed. The incubation period is from 3 to 30 days. Early symptoms include fever, chills, headache, fatigue, muscle and joint aches, swollen lymph nodes, and a rash called erythema migrans that occurs in approximately 70 to 80% of infected individuals. Erythema migrans begins at the bite site. It expands gradually over several days, reaching up to 12 inches or more in diameter, and may feel warm to the touch, but is rarely itchy or painful. It often results in a target or bullseye appearance. Later signs and symptoms may include severe headaches, neck stiffness, facial palsy, or loss of muscle tone or droop on one or both sides of the face, arthritis with severe joint pain and swelling, particularly the knees and other large joints, intermittent pain in tendons, muscles, joints, and bones, heart palpitations or an irregular heartbeat with Lyme carditis, dizziness, shortness of breath, inflammation of the brain and spinal cord, nerve pain, numbness, and tingling of the hands or feet. Early diagnosis and treatment with antibiotics can prevent later neurologic, arthritis, and cardiac symptoms and signs. There are two ways that increasing carbon dioxide, CO2, and resultant climate change alter food safety and nutrition. The first is associated with rising global temperatures that influence weather patterns and extreme climate events that in turn impact food contamination, spoilage, and distribution. Elevated sea surface temperatures will likely lead to greater accumulation of mercury in seafood. Rising carbon dioxide concentrations and climate change will alter incidence and distribution of pests, parasites, and microbes, leading to increased use of pesticides and veterinary drugs. The second is through the direct CO2 effect on photosynthesis, where higher CO2 concentrations stimulate carbohydrate production but decrease protein and essential mineral levels in crops, wheat, rice, and potatoes, changing the nutritional value of those food sources. The 2015 Climate Change, Global Food Security, and the U.S. Food System report added that climate change is very likely to affect global, regional, and local food security by disrupting food availability, decreasing access to food, and making utilization more difficult. Mental health and well-being consequences of climate change include stress and distress symptoms, anxiety, depression, strained social relationships, substance abuse, post-traumatic stress disorder, PTSD, suicidal ideation, and often interacts with and influences other factors of medical and physical health and community health, including interpersonal aggressive behaviors, violence, crime, social irritability, and decreased community cohesion, as diagrammed. Climate change currently causes, and is expected to continue to cause, a range of health impacts that vary across different population groups in the United States. The vulnerability of any given group is a function of its exposure to climate-related health risks, its sensitivity, or degree to which its people or communities are affected either adversely or beneficially to the change, and a community's capacity to respond to or adapt to a climate change variable. Vulnerable groups of people or populations of concern include those with low income, communities of color, immigrant groups, indigenous peoples, children, pregnant women, the elderly, people in vulnerable occupations, persons with disabilities, and those with chronic medical conditions. The National Center for Environmental Health includes the Agency for Toxic Substances and Disease Registry, ATSDR, an agency charged with conducting public health assessments of waste sites, conducting health surveillance, and administering registries related to toxic substances, and providing information, education, and training concerning hazardous substances. The 2022 ATSDR lists 275 substances on their toxic substance priority list. The top three toxic substances were arsenic, lead, and mercury. We will consider these three substances for a few minutes. Arsenic poisoning is called arsenicosis. Acute arsenicosis can present with vomiting, abdominal pain, diarrhea, and encephalopathy that can result in coma. Chronic arsenicosis can result in skin thickening and darkening, abdominal pain, diarrhea, cardiovascular disease, numbness, and cancer. The most common types of arsenic-related cancers include cancers of the bladder, blood, digestive system, liver, lung, lymphoma, kidney, prostate, and skin. Arsenic exposure during pregnancy can lead to maternal and fetal death. The primary routes of arsenic exposure are via ingestion and inhalation. Approximately 70% of arsenic is excreted, mainly in the urine. In the United States, the main source of arsenic exposure is through arsenic-containing food with meat, fish, and poultry, accounting for 80% of dietary arsenic intake. Fish arsenic has low toxicity to humans and is rapidly excreted in the urine. Well water contaminated by natural arsenic sources has caused toxicity globally. The World Health Organization in 2001 reported on widespread arsenic intoxication from well water in Bangladesh. Major sources of inhaled arsenic may come from burning of fossil fuels that contain arsenic, for example, burning wood preserved with arsenic, cotton gins, glass manufacturing, pesticide manufacturing, smelters, and tobacco smoke. Currently in the United States, the arsenic released by human activity exceeds amounts from natural sources by at least threefold. The major sources of arsenic released to the environment through human activity are arsenic-treated lumber discarded in landfills and byproducts of coal-fired power plants. Areas in the United States with the highest natural groundwater concentrations of arsenic are the Southwest, Northwest, Northeast, and Alaska, especially areas with geothermal activity. The U.S. Environmental Protection Agency, EPA, maximum contaminant level for arsenic in drinking water is 10 parts per billion. Surveys of U.S. drinking water indicate that about 80% of water supplies have less than 2 parts per billion. 2% of U.S. water supplies exceed 20 parts per billion of arsenic. The most heavily exposed people in the United States are in those industries that use arsenic-containing compounds, including carpentry, copper or lead smelting, electronics manufacturing, and pesticide application. One of the ATSDR lead programs is the Childhood Lead Poisoning Prevention Program that supports state and local public health departments with funds for lead surveillance and prevention. Lead is a naturally occurring metal, and intoxication is often due to lead ingestion or inhalation. The most common lead sources include peels and chips of lead-containing paints, which were commonly used before 1978. Another common lead source is contaminated water associated with lead pipes and lead-containing plumbing fixtures, usually installed prior to 1986. Lead enters drinking water through a corrosion-dissolving reaction, enhanced by high water acidity and/or low mineral content. Other lead sources include soil near airports, highways, or factories, often contaminated by lead from petroleum products. Some imported candies, traditional medicines, toys, and jewelry, and certain jobs and hobbies that use lead-containing materials. Parents who work in lead risk industries like battery manufacturing or renovation of older homes can inadvertently bring lead dust into homes on their clothes, shoes, skin, hair, and hands, exposing their children to lead intoxication. Highest risk groups include children younger than 6 years old, especially those from low-income households, since low-income housing units are more likely to contain lead-based paint and have lead-containing pipes and plumbing fixtures. Young children have a higher risk of ingesting lead due to their hand-to-mouth behaviors. Other high-risk groups include pregnant women, low-income households, and minorities, for example, African American, immigrants, refugees, recently adopted children from developing countries. Lead-based paint and lead-contaminated dust are some of the most widespread and hazardous sources of lead exposure for young children in the United States. Lead-based paints were banned for residential use in 1978. When lead-based paint peels and cracks, it creates lead-laden dust particles that can be ingested or inhaled. Approximately 29 million housing units in the U.S. still have lead-based paint hazards, with 2.6 million of these units containing young children. Lead intoxication is more harmful for children under 6 years old and can cause short and long-term effects, including damage to the brain and nervous system, slowed growth and development, learning and behavior problems, hearing and speech issues, lower IQ, reduced attention span, and reduced school performance. Women can pass lead to their baby via the placenta during pregnancy or through breastfeeding. Pregnancy-associated lead intoxication can result in miscarriage, premature delivery, poor fetal growth, and fetal nervous system and kidney damage, and child learning and behavior problems. Formula prepared with lead-contaminated water can also be a source for lead intoxication in infants. There is no safe blood lead level BLL, since even low levels are associated with developmental delays, difficulty learning, and behavioral problems, and those effects can be permanent and disabling. A blood lead level test can help determine the level of intoxication and an appropriate treatment plan. The average BLL for children in the United States is 3.5 micrograms per deciliter. Approximately 500,000 children in the U.S. have BLLs over 3.5, and the CDC recommends actions for those children. Once ingested or inhaled, lead is absorbed, and the blood lead levels rise. Once lead exposure ceases, the amount of lead in the blood decreases gradually, being excreted through urine, sweat, and feces. Lead is also stored in bones, and it can take decades to reduce bone levels. CDC supports primary and secondary lead exposure prevention programs. Primary prevention programs remove lead sources and hazards before a child is exposed and is the most effective way to prevent long-term effects from lead intoxication. Secondary prevention includes blood lead level testing, treatment, and follow-up programs. The 1986 and 1996 amendments to the Safe Drinking Water Act and the U.S. Environmental Protection Agency, EPA's lead and copper rule have reduced exposures to lead in tap water. Even so, there are still communities with lead service lines that connect homes to the main water line. Homes may also have older plumbing fixtures and lines containing lead. Mercury is a metal element found in air, water, and soil. It exists in three forms: elemental or metallic mercury, inorganic mercury compounds, and organic mercury compounds. Elemental mercury is liquid at room temperature. It's used in thermometers, dental amalgams, fluorescent light bulbs, some electrical switches, mining, and some industrial processes. Inorganic mercury compounds are formed when mercury combines with other elements, such as sulfur or oxygen, to form compounds or salts. In the body, elemental mercury can be converted to inorganic mercury. Inorganic mercury compounds are used in some industrial processes and to make other chemicals. Inorganic mercury salts have been used in cosmetic skin creams outside the United States. Emissions of both elemental or inorganic mercury can occur from coal-fired power plants, burning of municipal and medical waste, and from factories that use mercury. Organic mercury compounds are formed when metallic or inorganic mercury combines with carbon through the action of microscopic organisms in water and soil, creating methylmercury, which accumulates in the food chain, including certain freshwater and saltwater fish, marine mammals, and fish-eating birds. Thimerosal and phenylmercuric acetate are other types of organic mercury compounds made in small amounts for use as preservatives. Thimerosal is used as a preservative in some vaccines. People may be exposed when they breathe air containing mercury vapors in workplaces, including dental offices, smelting operations, and locations where mercury has been spilled or released. Burning of municipal and medical waste used to be a major source of mercury emissions. A significant reduction in mercury use, along with state and federal regulations, has resulted in a 95% decrease in emissions from these sources. Exposure may also occur in workplaces where inorganic mercury compounds are used. Exposure to organic mercury commonly occurs when eating methylmercury contaminated fish or shellfish. During pregnancy, methylmercury can pass through the placenta to the developing fetus. It can also be passed to the baby through breast milk. Pregnant women, nursing mothers, and young children should avoid or limit eating shellfish and large fish that contain methylmercury, including shark, swordfish, king mackerel, orange roughy, tilefish, and big-eye tuna. Salmon, shrimp, pollock, catfish, and sardines are low in methylmercury and also high in omega-3 fatty acids that are nutritionally beneficial. Breathing high concentrations of mercury vapor can rapidly cause severe lung damage. Long-term exposure to low concentrations of mercury vapor can result in neurological disturbances, memory loss, skin rash, and kidney abnormalities. A large ingested dose of inorganic mercury compounds can be corrosive and cause gastrointestinal symptoms. Long-term ingestion or skin exposure to inorganic mercury can cause neurological disturbances, memory loss, skin rash, and kidney abnormalities similar to that with long-term mercury vapor exposure. Ingestion of high concentrations of methylmercury over several weeks can cause neurologic damage. Pregnant women poisoned with methylmercury have given birth to infants with developmental abnormalities and cerebral palsy. Let's now discuss the National Center for Injury Prevention and Control and the National Institute for Occupational Safety and Health, NIOSH, for a few minutes. The National Center for Injury Prevention and Control works to prevent non-occupational injuries and violence and reduce their consequences by conducting injury and violent death surveillance, supporting injury prevention programs, and supporting and conducting research on injury prevention, care, and rehabilitation. The center's activities cover home and recreational safety, motor vehicle safety, violence prevention, traumatic brain injury, and injury response. The CDC's web-based injury statistics query and reporting system, WISCARS, provides an interactive online database detailing non-fatal injury, violent death, and cost of injury based on expert sources. The table on this slide lists the top 10 causes of unintentional injury deaths using the WISCARS database for 2017. These 10 causes accounted for 96.7% of all unintentional injury deaths in the United States. Poisoning is on the top of the list, accounting for 38.1% of those deaths, followed by motor vehicle associated deaths and falls. These three causes accounted for 82.2% of the causes of unintentional injury deaths in the United States. According to the CDC, injuries are the leading cause of death among Americans aged 1 to 44 years old. One person dies from an injury every 3 minutes, resulting in approximately 175,000 to 225,000 deaths per year. For each person who dies from an injury or violence, 13 are hospitalized and 129 receive emergency room care. Millions of people in the United States are injured each year and survive their injuries, but are left with lifelong mental, physical, and financial consequences. Injury prevention has a strong evidence base, but translating this information into effective policies and practice is challenging and requires effective advocacy efforts. The National Institute for Occupational Safety and Health, NIOSH, has a mandate to assure that every man and woman in the United States has safe and healthful working conditions, therefore preserving the nation's human workforce. The Occupational Safety and Health Act of 1970 created both the U.S. Department of Labor's Occupational Safety and Health Administration, OSHA, and the CDC's National Institute for Occupational Safety and Health, NIOSH. Whereas OSHA has the responsibility of developing and enforcing workplace safety and health regulations, NIOSH was formed to provide occupational safety and health research to inform workplace safety and health. NIOSH not only conducts research, but also develops guidance and recommendations on workplace safety, disseminates information, and upon request, conducts workplace health hazard evaluations. In addition to its own research, NIOSH sponsors research and training through extramural programs and enters cooperative agreements with state health departments, academia, unions, and non-governmental organizations to participate in collaborative surveillance and research projects. In summary, the National Center for Environmental Health works to prevent illness, disability, and death resulting from human interaction with environmental toxins. Human-induced climate change is a significant threat to health globally. The Agency for Toxic Substances and Disease Registry, ATSDR, conducts assessments of waste sites, surveillance, and administers registries related to toxic substances. The top 3 toxic substances on the ATSDR priorities list are arsenic, lead, and mercury. The National Center for Injury Prevention and Control works to prevent non-occupational injuries and violence and reduce their consequences. The National Institute for Occupational Safety and Health, NIOSH, provides occupational safety and health research to inform workplace safety and health regulations.